Thank you to the Foundation for inviting me here. What I want to do is to make a link between yesterday, when we were talking about extending lives, health, and the biology of aging, and the two excellent talks we have had this morning, which have been looking at some of the social, economic, and broader public health implications. And can I thank the translators for keeping up with that last talk, which was at such a speed, but you did a wonderful job in translating. And I also have to say that everyone in Britain sleeps with their windows open. It is very healthy to do so, and we are taught that is what you must do unless it is foggy. If it is foggy, you must close your window. Otherwise, every night, you should have your window open. So, I'm going to talk about life expectancy and longevity. I'm going to put three big issues, I think, around the demography of life expectancy. I'm then going to raise three conceptions that I think all societies have got to consider, and I'm then going to turn to some policy implications based on the work that we've been doing with the UK government. First of all, I just want to talk a little bit about the first super centenarian. That's someone who made it to over 110. We don't know much about him. His name was Gert Bumgard, and he fought with Napoleon. He was born in 1789, and he died in 1899 at an age of 110. There have always been long-lived people. Around about that time in Europe, there were probably about 10 centenarians, people living to 110 in the whole of Europe. What has happened isn't so much that we're pushing back life expectancy or longevity for the individual, but more and more of us are living to these very, very long years. Just to give you some kind of an example, in 1850, when the pension policy was introduced by Bismarck into most of Europe, half the population of Europe had died at 45. Now, half the population of Europe can expect to make it into their 80s. So reflecting on Tito's talk this morning and how many governments are pushing back retirement age in line with increasing life expectancy, if we were to take Bismarck's model, where half the population was dead by 45, and yet the pension age was 65, then we should have a European pension age of 103. So clearly, we need to be looking slightly more creatively at these models. But let's start by looking at what is happening to life expectancy. The first question is going to be, will increases in life expectancy continue? Will there be an increase in the average years lived by humans? This is a life expectancy graph at selected OECD countries. If you look at the dark lines, they are female, the dotted lines are male, and right at the top, the longest life expectancies here, Japanese women and French women. They both have a life expectancy at birth of around about 88. Now, I'm not surprised in a way that Japanese women live so long. They have a slightly different genetic to Europeans. These women, older women, have had a very different diet, a different kind of lifestyle to many European women. But why do French women live so long? Particularly if we drop here down to UK women and US women, who are much lower. Why does the channel make so much difference between the life expectancy of the French and of the British? And one of the arguments probably is that the line should not be the channel, it should actually be through the middle of France, because it is a separation between the Mediterranean diet and the Northern European diet. And I think yesterday you heard a little about this. One of the arguments that the demographers make is that it is not so much that the Mediterranean diet is good for you, though probably it is, but it stops you eating rubbish. And the British and the French probably eat more bad food than the Southern European women do. But that is where we are at the moment. And then you can see, not surprisingly, this gap. Men live far shorter lives than women. In fact, mortality across the life course for all ages is higher for the male than for the female. But in fact, we know that actually one of the most important drivers of life expectancy is not really life expectancy from birth, but what is happening at our older age groups. Don't worry about the countries that are listed here, but look at the shape of this diagram. This is the contribution of mortality decline looking at 3 different age groups. Here we have those people under 30, the green, the brown are those people of working age, but the blue are people over 65. And for both women and men in nearly all the countries in this study, it's declining mortality at later ages that is now contributing to life expectancy. This is really important demographically because there was a myth that although we would push back death across the life course, we would never push it back post-65. And as recently as 1989, a very important demographic paper came out saying we will never have a fall in the mortality rates over the 65, and therefore life expectancy probably is going to stall. We now know that that is wrong. The biggest pushes in decline in mortality are happening in these very late ages. And if we look here, this is life expectancy, again in these selected OECD countries. This is at age 65. You can see, if anything, the gap between the top, Japan and French, falling down to the UK and US has increased. We'll talk a little bit about that in a minute. Look here that it isn't actually always stable. There are declines in the rate of life expectancy. That is also important, and I'll come back to it. But when we look at age 80, you can see an increasing gap and also real variations. When we get to age 80, there are such small numbers that something like a flu epidemic, where you have maybe 500,000 extra deaths in, say, Europe, would make a really big impact on life expectancy at those ages. Let's look at 2 other projections going forward. Those that I showed you were UN median projections. That's where we are at the moment. But what about the future? And this is a very important study that came out at the beginning of this year, published in The Lancet. This is probabilistic modeling using WHO data, female life expectancy at birth in 2030. And if we zoom into those top 10 countries here, this is South Korea. And the exciting thing here is that the prediction is that just over a decade's time, we will have life expectancy at birth for Korean women of over 90 years. That's half the Korean women will make it to over 90. And that is another myth. Again, it was believed we would never hit life expectancy. That's at the national level, not longevity, but life expectancy that was higher than a 90. But it looks by this particular modeling with this particular data that that's going to occur. So we've had UN data, increasing life expectancy, WHO data, probabilistic modeling, increasing life expectancy. And we can now look at this. This is a completely different database. This is the human mortality database. This also was published in The Lancet. A very different type of modeling. This looked at the oldest age at which at least 50% of a birth cohort was still alive. And if you look here, this is the 2007 birth cohort in these countries. This is Japan. The projection is half that Japanese babies that were born in 2007 will make it to 107. Here we have France and the US making it to 104. And we have Italy, which is here. Oh, where's Italy gone? Italy seems to have, oh, there's Italy. Italy must be hidden here somewhere. You must be between about 103 and 104. So 3 different types of data, 3 different modelings. Yes, it looks as if life expectancy at the population level, not longevity, but life expectancy is going to continue. This means, and I think you talked a little bit about this yesterday, that really the 21st century will be the century of the centenarian. This is some modelling that was done at Oxford on the centenarians in the UK. We currently have about 14,000 centenarians. Remember, in the 18th century, there were 10 in Europe. We have 14,000 alone in the UK. But it is predicted that by the middle of this century, we will have 500,000 people aged 100 in the UK. And by the end of the century, we will have 1.6 million aged 100. 8 million people living in the UK today will make it to 100. 127 million EU citizens are projected to make it to 100. Similarly, for the United States, there will be 6 million people by 2080 aged 100 in the United States. So it really is going to be the century of the centenarian. this is some work that was done by a colleague of mine, Jean-Marie Rabin. What the really interesting thing is that I talked right at the beginning about a super centenarian, someone who has made it to over 110. And the real question is, as we push back life expectancies beyond 100, are we also pushing back late life expectancies? Will we have more and more of the population living to over 105, 110? And until now, we haven't had the data to show this. But we now have sufficient data in the UK, in France, and in Japan to be able to show this. And I just want to show this modeling because this is change in the distribution of ages at death for women in Japan, comparing 1950 to 2004. And you can see here that as we push back this modal, so we are extending out life expectancy. And in fact, if we compare the red, which is 1980, and comes to here, with the black, which is 2004, even in that small period of time, we've pushed back longevity at later life. However, some people are saying this is going to stop. Life expectancy was all about lucky cohorts. We pushed back death across the life course. We know how we did it. We did it through public health, nutrition, sanitation in the 19th century. Then we had more public health initiatives at the beginning of the 20th. We had vaccinations and antibiotics. Then we had geriatric medicine. And that now will come to an end. So people have been looking out for this idea that life expectancy is going to start dipping. And indeed, very interestingly, round about 2015, in the EU, there was a fall in many countries in life expectancy, and also in the US. So was it a statistical bleep? Was it that there were flu epidemics that were particularly bad? And remember, when you get to these very, very late ages, small numbers, you only need a small epidemic to really start dipping it off. Was it something to do with the fact that the trends, as we saw, have tended to go up and down? Or is it because it happened across the high-income countries, something to do with another factor that may be occurring? And what are the implications of that factor? So two very influential papers have recently come out in the BMJ and in Epidemiology, both this year, and they have made the argument that it's growing inequality in our societies that is leading to a reduction in life expectancy at the national level. Now, our previous speaker spoke a little bit about Michael Marmont. We know about the social gradient in health, but the argument is that inequalities in high-income countries are growing to such an extent that they're impacting upon national life expectancies. So the next really key question for society is, will life expectancy increase for all socioeconomic groups? Are we all going to enjoy the benefits of life expectancy, or will it be for just a few? And I want to explore this with a study we've recently done at Oxford looking at inequality in mortality. We had access to 2.5 million occupational pension sets, of which 500,000 are already dead. Now, the really important thing is that this is occupational pensions. We're not talking about the kind of work, for example, that Michael Marmont and other people have done, where they take the whole population. We have already cast away those people who are poor, out of employment, etc. All these people are salaried. They have occupational pensions. What is the inequality in life expectancy and healthy life expectancy in this very specific group? When we compare UK life expectancies from age 65 for our bottom 20% and our top 20%, we find quite a difference. So at age 65, our bottom 20% tended to be low income, tended to retire in health, and importantly, had an unhealthy lifestyle across the life course. And we compared that with our top 20%, high income, good health, and a healthy lifestyle. We found a difference of 11 years. At 65, one group made it to 12, had 12 years life expectancy left. Our high group had 23 years life expectancy left. And when you extrapolate that across the remaining life, the proportion of men in this particular graph, that were expected to survive to each older age. By the time you get into your 80s, there's a 50% probability at each year that you will die between our lower and our upper groups. The blue are the healthy, high income, and the green are the ill-healthy, typically low income. What we then did was to look at the impact of different factors on longevity. And some of them actually were quite surprising. So at the top, we have our bottom 20%, typically manual, poor, unhealthy lifestyle, ill health retiree. Remember, they only had 12 years left at age 65. If this man had done a non-manual job, he would have increased his life by 0.7. If he'd retired in normal health, 1.8 years. If he'd had a high income, 4. But most importantly is if he had had a healthy lifestyle, 4.6 years. And I think that indicates two things that we've actually heard about this morning. One, a life course approach is absolutely crucial. You cannot start tackling late life health at older ages. It has to be across the life course. So we know not only life expectancy is varying by socioeconomic group, there's a social gradient, but also healthy life expectancy is varying. This is some work that we did for the Government Office of Science, the UK government, as part of the ageing review that I'll talk about a little bit at the end. Here we have the most deprived areas in the UK, and here we have the least deprived or the richest. And by this particular map, if you are, again, we've looked, in this particular presentation, looked at men. If you are a man who is living in the most deprived areas at 65, you can expect to live till you are 81, but only 6 years in good health. If, however, you're a man living in one of our richest areas in the UK, you can expect to live to 86, but 13 years in good health. And this obviously has huge implications for the kind of things that Tito was talking about this morning. Because I referred to right at the beginning, we are pushing back pension ages in line with national life expectancy. But there is huge variation. And we know that those people in certain occupations, lower income, less education, they're the ones that are going to go into ill health much earlier. And I think there is a real concern that as we push back the state pension ages, and one can understand why governments want to do this, so you may have more and more people in their early 60s having to go on to disability benefit because they simply cannot work, particularly in those occupations where we tend to have low healthy life expectancy. So the really key question, I think, isn't life expectancy, but it's this. It's advances in healthy life expectancy. So will the advances in life expectancy be matched by advances in healthy life expectancy? I think you talked quite a lot about health yesterday, and you also talked this morning about some of the public health implications. But what I really want to look at is the impact of this, which is obesity. So people are always saying to me and my colleagues, you talk about life expectancy, but we all know that obesity is going to reduce life expectancy. Well, actually, all the evidence is quite the opposite, that obesity probably won't reduce life expectancy, but it will reduce healthy life expectancy. And the reason is that if we look at what happened last century, one of the really big public health curses was smoking. Particularly among men, and we know that the high number of deaths of midlife men was from lung cancer, cardiovascular disease, and stroke, and that these were connected with smoking. And in the UK, there was a very influential study that came out, in fact, out of Oxford in about the 1960s, which made the link between smoking and cardiovascular disease. And the UK had a massive public health campaign, and the impact was such that from the 1980s onwards, there is a dramatic decline in the UK of deaths from men from cardiovascular disease and stroke that exactly matches men giving up smoking. We tackled it in the way that our speaker this morning talked about, public health. However, we know that many of the ways that countries are tackling obesity is actually different. They're not necessarily using public health. They're using other means. One of the means that they are using is drugs. So instead of public health initiatives, we are popping pills, statins, blood pressure tablets, etc. And I think the modern argument is that life expectancy will not be reduced, but we will be living with these chronic diseases caused by lifestyle factors for far longer. So this is a very influential paper that came out in 2005 by Jay Oshansky, who was a colleague of mine from Chicago. And he predicted, in fact, that life expectancy would not continue in the US. In fact, he actually thought that the AIDS epidemic was going to have a big impact. But he also said, we anticipate that as a result of substantial rise in the prevalence of obesity and the life-shortening complications, which often are connected with obesity, such as diabetes, etc., life expectancy at birth and older ages will level off. That was in 2005. We now have some very, very good data that supports the idea that actually it's not going to reduce life expectancy, but it could well increase disability. And I just want to give you one example. This is from a large Dutch study from the Netherlands. And what they did was they looked at the main killers: alcohol, smoking, and obesity. And in this particular graph, we've just put age 55. Did it reduce life expectancy, or how much did it increase disabled years? And if you look at smoking and alcohol, so smoking and alcohol abuse, either way, can reduce life expectancy between 3 and 4 years, and it also increases disabled years by roughly the same. But all the evidence from obesity was that it only reduced life expectancy by 1.4 years, but it increased disabled years by nearly 6. This then leads into a very different scenario, because it says that instead of having fit, healthy adults who will be living long lives, able, as Tito was arguing, to remain in the labour force, in fact, we could have adults who are living with chronic conditions for far longer, and that completely changes the way that society is going to have to cope. So I'm just going to raise 3 broad issues and then look at some policy implications. So, issue number 1 is, if we are going to have a society where we are going to have people living well over 100, but the last 20 or even 30 years of their life are going to be beset by chronic conditions, what happens to the generational contract? And this has been inferred this morning, but it's a very simple concept. All societies have it, and that is that when you are an adult, you have children, child dependents, you care for those children. When those children grow up, they care for you. Now, in traditional societies, this happens through households and families, and in modern societies, we do it via taxation and public welfare. Many people are now beginning to argue, and you find it not only in the scientific debate, but also in the public debate, that because the current cohorts going into later life have been very successful in terms of reducing their fertility, they've had less children, therefore, if you like, less of their consumption has been drawn down to child dependence. They've benefited from that. They've reduced their own mortality because they're living longer. Maybe we need some kind of an adapted contract, a contract where people have more responsibility for their later life. They save more, they work longer, maybe they pay more taxes. But this idea that we have very large, older, frail, dependent cohorts relying on younger cohorts is being questioned in the public domain. However, we could go on to this. We could say, no, everything's going to be fine, we're all going to be living longer, and in fact, we're going to be living longer in good health. So we are going to be able to be contributory and work longer well into our 80s. If we're going to live for 100 years and we're still working in our 80s, surely that solves all the problems. This represents generational succession. And that is the concept that in all societies, again, one passes down power and assets and wealth and status down through the generations at a very regular pace. So what happens when you don't inherit from your parents till you're 80, or from your grandparents till you're 80? what happens to our world of work, to our world of politics, to our world of communities? And that's where, as Tito was talking a little bit about this morning, that whole generational conflict idea comes in. And it's something I think that increasingly, when we look at how to cope with an aging population, it isn't just the inequality that I was talking about, inequality within a generation, but we have to put into that frame inequality between generations. And then finally, I think the other really big concept that societies have got to tackle is this. This is Shakespeare. This is the 7 Ages of Man. Interestingly, the top 3 were old. He saw heterogeneity in old age, maybe more than we do today. If we're going to be living half our population to 100, are we going to have 12 ages of man? Or are we going to move to a fluid life course? And I think a lot of people are now beginning to really look at this again from a life course perspective. In the UK, and I think somebody mentioned it in one of the questions, we say to our young people, stay in education till you're 25. Or you can retire in your 50s and you're going to live to 100. That's 30 years of productivity in a 100-year lifespan. And many people are now beginning to question the idea that we need to mix education across the life course. We've got to upgrade our skills, particularly in a highly technological world. Therefore, the idea that you stop formal education in your 20s, education should be across the life course. Work should be across the life course. And as Tito was talking earlier, you can change things. Shorter working days, working weeks, or maybe periods when you're younger, when you actually withdraw from the labour market. Quite often, I've got 3 children, and when my children were younger, I would look and there were all these people in their 30s and 40s who were absolutely pumping out their careers, and they had young children, and on either side there were students and older retired people. Maybe we need to look at that kind of fluidity. So fluid life courses are something, if it's going to be 100 years, that I think we have to look at. So drawing on the work that I recently did chairing the UK review of ageing population, this, I think, is the major research and policy challenge. In the context of age structural change is that move from predominantly young to predominantly older populations. The challenge in all regions is going to be how to sustain and enhance well-being across an individual's life, while at the same time reducing inequality within a generation and ensuring equitable reallocation of resources between the generations. And one of the things that we did in the UK when we were asked to set up this review of the ageing population, a 2.5-year review on how Britain could cope with its ageing population, we didn't just look at pensions and we didn't just look at long-term care. We believed we had to look at every aspect of the UK's life, productivity and employment. And it is productivity, not only from the economic point of view, but also taking on board unpaid care, volunteering, etc., that so many of us do across our life course that isn't economically rewarded, but is very valuable. The whole way our families and communities were restructured, something that came up in one of the questions. Lifelong learning was absolutely essential for the UK to cope. Health and social care, housing. Housing increasingly is an incredibly important factor that we should be taking into account. Particularly going forward, our houses are going to become our places of work, our places of care. They're going to hold our finances, how we transfer wealth down through generations, whether they're a burden or not. And then the whole connectivity, intergenerational connectivity, digital connectivity, transport connectivity. Our public environments have got to change as we have more and more older adults. Within a decade, half of the population of Western Europe was going to be aged over 50. Again, with life expectancies well into their 80s and 90s. We need to transform our physical environments as well as our working and educational environments. So to conclude, these were the conclusions from that report. We need a strong and resilient health and social care system, which enables appropriate health and social care provision addressing the different needs across the life course. We need to ensure we have appropriate, safe and secure living environments, enabling supportive daily living, social and economic activity and health and social care. Our working environments must change to promote and support economic activity for all ages. We must have a sustainable, integrated transport system which allows people of all ages to undertake the activities across their lives. Access for lifetime education has to be part of the UK going forward, not only for work, and actually there is a really big question here, who's going to pay for this lifetime education? Is it going to be the employer? Is it going to be the individual? Is it going to be the government? Maybe it should be the government, because we have to enable individuals to cope with the increasing complexity of life, to care for others. And in particular, I think when we look at the way that we're going to talk about in a minute, technology comes into our lives, we really need this idea of upgrading and increasing our skills across our life course. There has to be more societal recognition of the role that families and communities play. And just as the last talk ended on, we need a sustainable governance framework which promotes the resilience of individuals in the light of increasing personal responsibility for well-being, enabling them to thrive. The words thrive and flourish are very big at the moment in UK public policy. One of the problems is that we are still constrained by 20th century institutions trying to tackle 21st century problems. Our workplaces are still ageist and do not support life across the workforce. Our education systems are ageist and do not support education across the life course. And as we heard a few minutes ago, even our healthcare systems in many cases are still geared up for acute infectious diseases, are shifting to chronic diseases, but not the kind of healthcare systems that necessarily can cope with the comorbidities that we find in later life. This is a picture of Oxford, which obviously is a lot older than the 20th century, but I think it makes that point really importantly. Our institutions and our governance have got to change to cope with the demands of increasing life expectancy and ensure that we have healthy life expectancy and equal access to successful aging across the life course.